was a resident when I've been to Naples in 2006. And since then, he's been working with Professor Capabianca and Luigi Cavallo, that are very well known in all the world. This Domenico is now an assistant professor at the University of Naples. And Naples is my second home. I feel home there. This is a very important group of friends and a very important group of neurosurgeons that I think trained a lot of people from everywhere in the world, and they published and still publish a lot of papers and chapters and books on the subject of endoscopic endonasal surgery. Professor Capabianca is nowadays the president of the Italian Society of Neurosurgery. So they are a very active group of skull-based surgeons. So I'm very glad. It's a great pleasure to have you here, Domenico, with us for this webinar. The subject of this talk is craniopharyngiomas, the nasal approach, I think, is the main topic. And this is intended to be more a lecture to residents. This is the second lecture of this group of 6 lectures on the subject of skull-based surgery. So please, Domenico, feel free to start to talk. Thank you very much.
Thank you, Mateus. Really, it is a pleasure and an honor to be your friend, and it is an honor for me to receive your invitation. Thank you, Dr. Ghisoni, and all the team at Unicamp for having me here. I think that my presentation is useless since last week João Paulo de Almeida already taught you everything that you should know about the skull base. I don't know if he's here. JP.
I'm here.
Forgive me for my stupid lecture, okay? So,
Domenico.
This is our experience. Of course, as Matteo said, we have since 1997 started the opportunity to work with the endoscopic endonasal approach. And this is our city. You see on the left side, this is the volcano that we have that is called the Vesuvio. And on the other side, we have Federico II, the emperor who distributed our university. And the third deity is that suddenly left last year. I know that all of you is Brazilian, but this for us is a special god that lived in Naples. But let's talk about this topic that is one of the most tricky topic for a skull-based surgeon, either if you start your procedure from the nasal standpoint or you go transcranial standpoint. Why? Because craniopharyngioma is still classified as a benign tumor. The WHO still call it a benign tumor, and suddenly it can also have all the features, that molecular and biological features that defines its characteristics of being benign. But what is the most strange thing, and it is called as Janus biface, like in the old Greek mythology, because on one side you will have this characteristic that you will have when you observe it on the microscopic or electronic microscopy. But if you look at the surgical field, then you notice that the tumor has invaded many important structures, like the hypophyseal hypothalamus duct. It can invade the pia, it can invade the hypothalamus, it can invade also the posterior aspect of the interpeduncular fossa. And the most important thing is that you can never know, either if you have a great surgery at the first shot, what will be of this patient, especially if this happens in children. And of course, you will have to manage the recurrence that suddenly it will happen at a certain moment. So all this treatment you should consider one time, many times, or combine it, and you have to be prepared to use all of them and to upgrade and update yourself to find out what is the better solution for everything. But speaking of surgery, as we are all surgeons, our treatment, it should be always done at first time, and we should do our best at first shot, because like when we go for a primary tumor, then like the rate of complication and the rate of morbidity can be lower, because there is not that adherence, there is not that complication that the craniopharyngioma with the process of adherence starts when it gets to be a recurrent. So we were talking before with Dr. Ghisoni about our policy in Napoli. Our policy is basically what we learned from the literature of our masters that have done this kind of surgery before. You should go for an aggressive tumor. You should go to remove as much as is possible. So you have to aim for a gross total removal, but you cannot forget that if you remove the last cell of the tumor, you maybe wind up entering hypothalamus structures or stalk. So the complications perioperatively will be tremendous, especially in children. You see, like in the first time that Harvey Cushing defined this kind of tumor, it is for call it as the most forbidding of the intracranial tumors. And thereafter, he said that it is not possible to enucleate the tumor. And what I said before, like that if you go for the first surgery, you only go for a biopsy of the tumor and you try to clean what you can see from a transcranial route, then the second time it will be impossible. And of course, like the second operation that inevitably will follow, it is useless. And for us, the real nice thing is the reddish communication. It is that the nasal route is of course impractical and cannot be ever like useful. Then RD, like in 1971, was the first to say that this can happen. Like you can achieve a good trajectory coming via the transphenoidal route using the microsurgical technique, but you have to be prepared to deal with certain anatomical features that maybe the tumor itself has developed. So if you have like a tumor that has pushed like the floor of the cella down, so enlarged the cella and already managed like the patient to got hypopituitarism, then you can have like a good and convenient corridor and you can perform the transphenoidal route. And of course, like he just recommended like to check out to be sure that the tumor was subdiaphragmatic. And still in 1980s, like Dr. Cyric from Evanston's, like from Yugoslavia, then working in Evanston, says like, if you use like the transphenoidal approach, do you need to be a virtuoso? Like, do you have to reserve this corridor only for people that are extremely brave or extremely familiar with this corridor? We cannot do. What we can do is like that you have to consider all the relation that the tumor can develop along its growth pattern. The first like was made out by Yasargil, and you see it concerns like the stalk and chiasm. So you can have different growth pattern and different involvement of the stalk and of the chiasm. And then for children, you have this French categorization that has 3 degrees of invasion. You see the 0, it is when you do not have supradiaphragmatic extension. You will have the grade 1 when you will have supradiaphragmatic extension, but you see this tiny here hyperintensity, maybe it is the floor of the 3rd ventricle. So you can say that the ventricle, it is not invaded, and eventually there is no invasion of the hypothalamus. And then there is this terrific situation where you cannot recognize anything inside the 3rd ventricle. You cannot recognize the stalk, and you only have the perception here of the gland below that. Nowadays, in 2014, we have been invited to write this paper about the craniopharyngioma, and there are certain craniopharyngiomas that can be easily accessed and safely removed by the endoscopic endonasal corridor. We refer to this classification as initial consideration when we perform the ventral route, and it has been described by Kassan in 2008 in his group in Pittsburgh. So you can have like basically 4 types of craniopharyngiomas according to the growth pattern and according to the relation to the infundibulum. So you will have like a tumor that can grow and push the infundibulum behind, or you can have like a tumor that grows inside the infundibular stalk lesion, or retroinfundibular tumor with the stalk and all the infundibular lesion that close like your view when coming from a ventral route. There is the fourth grade of tumor that is purely intraventricular that recommends to not be performed via endoscopic endonasal route. But maybe like in 2016, this is even like a more nicely classification, because it does not address like the neurovascular structure to refer to, but it just analyzes like the cells of the hypophyseal hypothalamus region that gives like the different kind of tumor development. So this group of Chinese authors says that if you will have like tumor developing from the pars intermedia of the gland that separates the anterior from the posterior pituitary gland, then you will probably have like an infradiaphragmatic tumor that has its major extension inside the cellar. So you will face a tumor that is basically an adenoma, giant adenoma that starts from the cella and then develops outside, but it can be still subdiaphragmatics. But what happens if you just start to having tumors that has epicenter of growth in the stalk? So you will have eventually what we can call type S tumor, as or like type 2 as for Krassan classification, that invades the stalks but can displace the third floor ventricles above and posterior to the tumor, or just infiltrate the most anterior part of the third ventricle, lamina terminalis, and so on. Or you can have tumor, and these are the worst category of tumor, that starts their growth from the tuberoinfundibular region. You see here the red dotted line, and you will have tumor that extends inside the infundibulum and invades the cavity of the third ventricle and eventually gets like subpial invasion. We had also our classification very basic, and it gets like the relation, it underlines like the relation of the tumor with the floor of the third ventricle. Why? Because like if you says that the ventricle is far away from the nose, then you will be discouraged to perform like the endoscopic endonasal corridor. But whether if you have like a tumor that is a huge tumor that starts like in the infundibulotuberal region and pushes down all the contents of the third ventricle floor and pushes the stalk and pushes all the supradiaphragmatic area towards like the tuberculum cell and the supracellular space. So eventually, as long as you open and you do not have the chiasm that is post-fixed, you can enter safely that area and start dealing directly with the tumor without crossing any particular neurovascular section as in transcranial corridor. So this is only like a further anatomical consideration that we developed managing this kind of tumor, that with the endoscope you can enter the ventricle and you can divide the ventricle areas in 4 areas. And what we can do nowadays is entering, of course, the infundibular and foraminal region, the mesencephalic, if we look posteriorly after the removal and sliding toward the thalami, but we cannot go above to the tectal region with the endoscope coming from the nose. So here it comes like the real problem of the craniopharyngiomas. This is our clinical and surgical series published in 2014. This is our skull base, the whole pack of patients that started in 1997 as that's been performed purely endoscopically endonasal surgery. You see, the most part of it are adenomas, regardless the size, and 131 craniopharyngiomas that started to be treated like around the first year of 2000. And this is the details for craniopharyngiomas. You see that we performed 35 what we call standard procedures. So it means that we targeted toward tumors that were subdiaphragmatic. So the tumor did not breach the diaphragm, and the opening of sella was enough, and the dura was not breached. No reconstruction, no CSF happened. And 96 of these tumors were extended procedures, and you see that 71 was primary surgery and 25 were recurrences that either came from other hospital or from people that we did already operated on. And this is a particular only to show that we are not that familiar with the pediatric craniopharyngiomas. Our center here in Napoli, that it is called Santo Bono Hospital, that is led by Giuseppe Cinali. Sometimes when the child is already like more than 6-7 years old and has a good nasal cavity, refers to us for the endoscopic endonasal treatment. So we collected like 16 patients out of 131. But again, what it is very nicely underlined here is that most of the children develop like an infradiaphragmatic corridor at first tumor growth. So maybe it is better for them like to have like a ventral route and to not manage via the hypothalamus stalk region. So entering the surgery, to remind here, with this the corridor that we face here in Napoli, the experience started in 1997 with the standard endoscopic technique. Again, we never use the nasal speculum or the transpheredal retractor. All of our team got a lot of endoscopic endonasal dissection, and it is familiar with this aspect. So here, like, it is not important to open widely the nasal structure. It is not important like to know perfectly like the nasal anatomy, but what you have to be familiar with is your mirror, your door to the skull base, because sometimes it can be a decent corridor, sometimes it can be a very narrow corridor, and all the major neurovascular structure, the optic protuberances and the carotid artery can close the door and gets you in trouble. This is only a reminder, like to see that eventually also the lateral wall of the sphenoid sinus can be tricky, the nasal cavity can be tricky, but the only thing that nowadays we are managing is this here reddish portion of the nose. That is basically the pedicle of this huge chunk of mucosa that the two Argentinian otorhinolaryngologists taught us. Like the nasoseptal flap, it can be very, very useful, like to reconstruct the skull base after the tumor removal and with a very wide opening of the supracellular cistern and so on. Here, like anatomic detail, this is a specimen coming from the Vienna Institute. Dr. Cavallo performed this dissection, and you see here that reddish part that we saw above the roof of the choana. It is the nasopalatine artery. It comes from the sphenopalatine artery that comes from the maxillary artery. And you see here, like if you are not aiming to go for a nasoseptal flap, this is a regular endoscopy for adenoma, and here we are biting with these sharp instruments the mucosa over the anterior wall of the nasal, the anterior wall of the sphenoid sinus, and you see here at a certain point it will start bleed. I'm not sure it is working properly. It is working very slow. I hope that you can see it.
Yeah, we're seeing it, but it's not
very slow, right?
Normally, yeah.
Okay, just stupid thing. Okay, and then again, this is our perspective. We came from being pituitary surgeon, and then we extended our horizon. So as long as you consider the craniopharyngioma a pituitary tumor, because it invades and it involves the pituitary and hypothalamic function, you have to be perfectly knowing the pituitary gland and all the vascularization and all the surrounding structures, because all of these can be involved. And if you enter this area, you see here of the pituitary stalk and in the chiasm, you cannot cut, you cannot coagulate these vessels, because otherwise, like, the chiasm will be not anymore supplied, and the stalk, either if it is represented by anatomy, it will not have a proper function. And this is our endocrinologist that says, like, after being like a surgeon, like, remember that the patient should come to me, so please make as low deficit as possible. So standard approach for subdiaphragmatic craniopharyngioma. We start with the cases. You see here, like, this is probably the diaphragm here with the gland eventually stratified on it. Like, can you see here also this hyperintensity? We were not sure that this was a craniopharyngioma, although this black spot here in the posterior part of the cellular floor supposed to be a calcification. So this is the surgery. Again, this is a forehand surgery technique. We are two surgery, Professor Cavallo and I, and we go closer with the endoscope, and you see here, this is the suprasellar cistern, the diaphragm that has been invaded. This is CSF coming out. This is the remnant of the pituitary gland that you can dissect, and then you can use, like, to cover the suprasellar cistern. This is a piece of tacosil that helps, like, in achieving, like, a proper hemostasis and also the sustain for the suprasellar cistern. When we go further and we look for craniopharyngiomas that invades the supradiaphragmatic space, we need to move to this other corridor that it is well known to be called, like, transtuberculum transplanum. This is the first approach that we described, like, with the craniotomy going from the upper part of the cellular floor, passing through this tiny spot here that is called, like, the medial OCR, that represents, like, the bone that gets in between, like, the canal of the carotid when it starts to be intradural with the canal of the optic nerves on both sides. And this is a nice, again, like, pictures that comes from the labs of Vienne with the suprasellar transtuberculum transplanum approach well done. You see here, we have not extended that further on both sides above the optic nerve and anterior to them, because there is no tumor to be removed. But be aware that you can open widely here above the optic nerve without encountering any particular structure. The only concern that you have to manage, it is the wide opening, and eventually, like, to be prepared to have, like, a tough reconstruction procedures thereafter. You see here again, like, the stalk, it is the main the key point of your corridor when you open this kind of approach. And you see here, like, we can see the gland is pushed here. This is the chiasm, and we are working in between, like, the stalk that you see here displaced and the chiasm. We are dissecting the tumor from the retrocellular space. That was the basilar tip with the posterior cerebral arteries. And if we push down the chiasm, then you can enter the ventricular cavity. The stalk is here, like, the ventricular cavity was free, only a tiny calcification. So what we have to manage when you perform this corridor, we have to be safe that we have enough space so the access corridor, it is adequate. We have to study perfectly the relation of the tumor with the chiasm and the major vessels of that area. And then we have to recognize where it is the stalk, if there are adherence or invasion of the hypothalamus and infundibular region. Why I'm telling you this? Like, because this is here like a trick. We call it this area like suprasellar notch, but basically it is the tuberculum cell, and it can be like a different degrees. And if you have different degrees, then you have to use different materials to fill up the space when you go for reconstruction, and you can have like different kind of performance when you go. And if you have like a different angle, you have to consider that as long as you look at the monitor in a 2D video, then the perception of the planum will be different. So you have to remind in your 3D re-elaboration when you're performing surgery, if you're going up, it is not up, but it is anterior, and vice versa. If you're going down, it is posterior. And the space in between the suprasellar and retrosellar with the interpeduncular cistern, it is very, very little. So just study the relation at the MRI. Just remember that angle that can orient again. As well, like a CT scan, like a basic CT scan, can help you in defining special details like optic canals that are dehiscence, like or wide opening, and or like particular molding of the sphenoid sinus. And this is a particular of what Dr. Kassam called the suprasellar gate. Again, it is based on this tiny spot here. I told you, like, that is like the joining in between the two canals of the optic nerves and of the ICA. This is the distal dural ring, and these are the proximal dural rings that Dr. De Almeida showed us last week. And this was the first like shy attempt of expanding our corridor above, like at the level of the planum. Consider that nowadays we do not have any concern of opening widely, especially in case of meningioma, like performing like opening that really entangle all the tumor in between. But if we are analyzing the disease, then this is probably what we have to be very focused on. Where it is the chiasm here, like the chiasm is here, like the tumor is pushed anteriorly, like it was like prefixed, and that was a recurrent tumor here. Like probably Matteo was with us at that time, and you see that all the ventricle, like the floor of the third ventricle, it is at the level probably of the posterior, the dorsum cellae, and all the tumor develops inside the third ventricle. So you will have a corridor that it is like subchiasmatic, and you will have like a straight line coming from the nose, and your concern will be not the floor of the third ventricle that has been already destroyed by the tumor. In this case, you will have like a retrocellular craniopharyngioma, and you will have the stalk that it is pushed and enlarged in front of you. So you can easily go on both sides. Again, you are working subchiasmatic. What you can do is like to free the gland, like remove safely all the inferior aspect of the floor, of the cellular floor, like to push down or eventually cut a little part of the gland without causing any endocrinological sequelae. We do not believe in transposition of the pituitary gland because it is tough and eventually it will lead to panhypopituitarism. So you can reserve that maneuver only like to case in which the tumor has already created a severe damage of the hypophyseal function. And you see here, like the stalk was completely displaced. You cannot see, maybe here it is just posterior to this leaflet of dura, and you will have a nice corridor at the center of your field. And look, you do not need that wider corridor. You only have to have a straight median target toward the center of the tumor. That is the stalk. And this is a very nice question also. Maybe as long as every one of us started to thinking about craniopharyngioma, then we said like what to do with the stalk. Like we have to cut to avoid recurrence, or we cut it and then nothing happens. And of course, like the patient have postoperative endocrinological outcome. What you can see is like that several groups still claim for like postoperative endocrinological worse outcome if the stalk is cut. There is no evidence that the recurrence will not happen. There is this group here, like that told that eventually, like if you leave only a tiny remnant of the stalk, then you can have like perfect function of the hypothalamus, and the function of the hypophyseal is spared with no DI. Again, like we start with the cases of, you see that is the case that I showed you here. There is the chiasm, and it was a recurrent tumor. It has been already performed via transcranial corridor, and it has been also like received the placement of a shunt. And we have opened the gland, we have opened the floor, the cellular floor, we have opened above. This is one of the first cases that we performed here, like the wide opening, the chiasm is pushing like the corridor down. That was the shunt that has been cut and removed to enter the space posterior to the tumor that is inside the third ventricle. And you see here, these are the foramen more above, like this is the posterior aspect of the third ventricle, the adhesion interthalamica. And we continue to dissect with bimanual technique. And this is a big chunk of tumor with calcification. The gland is still there, and we did not recognize the stalk, but we do recognize these two protuberances that are the mammillary bodies above the floor, and it are like our arrest sign. You cannot go further in the section beyond that point. And you see, like that was the pre-op, and this is the post-op with this calcification here, like toward the stalk and toward the hypothalamic region. And that was probably one of the nicely first cases that we had. You see this tumor that can be called like a type 2 according to Gassam, that it is contained, like it is seated inside the stalk infundibular area. You can see here the hyperintensity of the anterior aspect of the stalk, and here like the posterior part of the stalk that gets inside the infundibulum with the mammillary bodies and the mammillary bodies and the encephalon. Again, like a nice surgeon, and you see here like the stalk, it is enlarged. This is the arachnoid. We do not see yet the chiasm. It is here the chiasm. This is the infundibular region that is behind. So you have to enter the stalk and like dissect from between. In that case, we've been very lucky because the tumor was soft, and this is the outer aspect of the stalk. This is the third ventricle with the infundibular aspect and all the chamber behind, again, like with the mammillary bodies that appeared here. This is the chiasm, like the right optic nerve with all the vessels below. And the nice surprise here, it was like that also at the postoperative MRI, you can see like both part of the stalk. So you can see like the two tiny pieces of stalk that remained attached and like are still functioning over the time. And this is like probably what we call like the most dangerous tumor, like the infundibular ventricular. So that tumor that starts developing at that area above the stalk, but in the infundibular region, and it involves also the cells of the stalk. So you will have like a part that is in the anterior aspect of the stalk and then enters the anterior aspect of the third ventricle and then extends posteriorly inside the third ventricle chamber. In this case, of course, like our job was eventually more easy because it was a cystic component going down, but still the dissection has to start like from the stalk, and you have to remove all the solid aspect, and then you can follow inside the third ventricle the cyst wall, and you have to try to dissect, otherwise it will close again, and 1 month again you will have the tumor or at least the cyst, so the patient will have again to be operated or like to receive like the drainage of the cyst. And you see here like we spend most of our days like to freeing this part of cyst wall from the third ventricle chamber. This is the posterior aspect of the third ventricle, the aqueduct, the adhesion interthalamica, and the stream medullaris there. You see here like we did not pull away that part, we only opened it, and this hyperintensity was the remnant, and the patient has received radiotherapy 1 month after surgery. Sorry, there we go. And that was also like a very nice case, like all developing in the posterior aspect, like behind the stalk. You see here the stalk, the tumor, the most part of the tumor gets in the posterior aspect, and here you have the third ventricular wall, and you will have the interpeduncular cistern. That was a young guy, like only 32 years old. And you see the mass appeared, the stalk is here below. You remove easily, that was a soft tumor. Again, like you will have the stalk. In this case, we did not extend our opening that widely above the level of the planum, but we prefer like to work in a straight corridor. You will have the gland here, and here you have the third ventricle and the lilequis membrane here. You see the integrity of the lilequis membrane. You see that we were washing again. The tumor has been removed completely, and the wall of the floor of the third ventricle, it is intact. Finally, this is type 4. It is intraventricular, but it is not the intraventricular that Kassam described. It was still a little contact here with the infundibular region, but it does not invade the stalk. So very nice tumor here, like new HD camera. You can see like the different highly definition of the left optic nerve, right optic nerve. This is accusa because the tumor was very solid, and we are working above the stalk but inside the ventricle. So again, like the dissection, it is bimanual. We are the two of us working, and you see too much movement eventually, like to find what is the proper angle of moving safely both instruments. At the end, like the foramen of Monro, here, like the floor, it is intact, no remnant above the floor, no invasion of the mammillary bodies. And this is a collection of images that we love to discuss with all our colleagues, because it gets like a really nice view over like what you have done in craniopharyngioma surgery. Like if you enter the ventricle and you look anteriorly and above, you will see this foramen of Monro, and you will see that dilated, because if the tumor entered the chamber, eventually like pushed upward the foramen of Monro, like constrained the CSF flow, and got like eventually several conditions of hydrocephalus. But if you have like a straight trajectory, like in the last case that we saw, then you'll see nicely the posterior aspect of the third ventricle with the stria medullaris, and you will slide in a direct corridor because the tumor has pushed down all the ventricular chamber. So the trajectory from the nose will not be to like climb up toward the upper part of the ventricle, but like it goes posterior, like to the encephalon. And finally, like you do not have to look at your shoes, like to look where you're placing your feet, and it is the floor of the third ventricle. And again, we love like to consider the mammillary bodies as our crucial key point for stopping surgery, and to considering like the difficulties of the tumor and hypothalamic invasion. And then finally, like we had reconsider other opportunities. We have a saying here in Italy. So if mama does pizza, then you'll eat pizza. So probably we try like to have as first choice in most of craniopharyngiomas the endoscopic endonasal route. But there are other conditions, and craniopharyngiomas, again, it is not only like to say something that we already know. Like craniopharyngiomas needs accurate discussion, and like needs really like the best solution possible, even in a monster case like that, because sometimes it is better like to have like two combined strategies as compared like to one single brave surgery. And we had the chance like of this resident that went to Lyon and worked with Dr. Joanneau. And we collected few cases, like 12 cases, 6 from the both schools. And we had like the idea that if you have like wide tumor that is oppressing the third ventricle, and you cannot have the safe condition for removing, then you can go via transventricular approach, transcranial transventricular approach, drain the cyst, and then refer to radiotherapy. And this is one of our last case that we performed this surgery. We were going first of all, our first choice was the endoscopic endonasal approach, because you see, like the solid part of the tumor stays here, like here you have the mammillary bodies, maybe the flora of the third ventricle, it is respected, but we thought that all the cystic component will be drained by the endoscopic endonasal corridor. But then this guy had like a severe heart attack, and it has been first treated like with the revascularization of the coronary arteries, and then he came for acute hydrocephalus, like 3 months after the cardiac procedure. So we said, okay, you cannot afford, like our anesthesiologist also said, you cannot afford wide surgery, go for 1 hour surgery, drain the cyst, leave a catheter, and then go for radiotherapy. And we did that. You see, very nice procedure, nothing special. We entered both cysts, and we tried also like to enter inside the interpeduncular cysts as in a TV. And you see that motor oil nicely came out. We never touched this solid part because we did not recognize any structure aside the foramen of Monroe. And then like the patient received adjuvant radiotherapy, and you see like the cyst completely collapsed and the solid part stays there. The patient did not develop any other disturbance of the visual field. Finally, only will give you a brief report of what we are doing today to close up the skull base. You know that this has been probably also always like a point of discussion in between surgeons that prefer transcranial corridors, because they said, okay, but you will have like a lot of postoperative CSF leakage, and then you will have like the third ventricle open, and then you will have like the gravity that goes against you. And we are trying this new technique that Professor Cavallo called it the 3F. And it is made out of fat, periumbilical flap. Then we use the nasoseptal flap. And then we ask the patient to go fast out of the bed to reduce the pressure if he stands up, and then he walk, and then he divert from the skull base the pressure over the defect that we reconstruct. Here it is the brief video. You see transtuberculum, transplanum approach, like a huge chunk of fat. It is used as a corkscrew. It is placed in the osteodural defect and it stays there. And nowadays we are trying also like to have the patient in a going with raise the head and then pull it down, like to reduce the pneumocephalus inside. And then we fix this fat with the fibrin glue, and then we slide the nasoseptal flap over it, and then we clog the sphenoid sinus with the Surgicel or whatever spongosan it is here. But Professor Capabianca and all the team, it is very, very like, how can I say, like focused on the education. So our talk, it is nice because, again, this is our way of understanding the thing about craniopharyngiomas. But we would like to also show these results. These are taken from the chapter that we had the opportunity to produce for the ICAR on endoscopy and endonasal skull base that has been published on Forum on Allergy and Rhinology. And you see here what we talked before, like also in huge series, the evidence of having like a subtotal removal, it is quite the same like as in radiotherapy. Subtotal removal plus radiotherapy, it is pretty the same in terms of recurrence-free survival period and overall survival as compared to the gross total removal. And these are the widest series that are so far reported in the literature for craniopharyngiomas. And also this, it is very, very nice, like about like the pediatric population, like what we have to do if there is like a pediatric tumor involving the hypothalamus. probably, like, I don't know, like if you ever asked like a pediatric endocrinologist, then he will say, oh, you left a remnant behind, I cannot go with the GH, the guy or the tiny girl will stay there, and I cannot go for a recombinant GH. This is not true, because it is a false myth. Again, like the evidence, it is that sparing the hypothalamus from surgery, it is better. And also radiotherapy can be better as compared to an invasive surgeon, also in pediatric population. And probably, like we did not say anything yet to craniopharyngioma, because a lot of studies are going on, like the group of Boston find out this BRAF mutation in papillary craniopharyngioma. Someone is called like the CTNNB1 for beta-catenin in adamantinomatosis. Someone is calling like for the radiomics and genomics. I have to tell that I've been lucky for the great group I stay with, and I have been very lucky because in 2006, like this great teacher here, like he came from Brazil and taught this guy that, I don't know if you know, this is Dr. Kassam, and you see how Mateus at that time was illustrating Dr. Kassam how to perform his surgeries, and I had the opportunity to have him along all this year with me. Thank you very much. Obrigado.
Thank you, Domenico. I think you can close your presentation. So
yes,
maybe we can share